and good evening, everyone. Welcome back to those who have seen one of the previous webinars that we've done, and obviously welcome to those who it's your first time. Obviously, slightly exciting format with the Q&A type model rather than me sort of talking for 50, 55 minutes. So it's a massive relief for me, but hopefully a really good opportunity to ask kind of more those pressing questions that you have maybe more as an individual, which is really exciting rather than kind of being railroaded down the content that I kind of talk about. But my name is obviously Cameron. I'm one of the co-directors and the lead clinician at what is now known as Foot Foundation. So we've gone through a bit of a rebrand, but one of the brands that we continue to operate is Fungal Nail Solutions, which is obviously a clinic, or actually a set of clinics that specifically has been designed to assess, diagnose and treat fungal nail infections. So my clinical role includes both being the lead physiotherapist and podiatrist for our clinics and our clinical team. And my day consists of kind of a mix of clinical caseloads, bit of business management, clinical training of our staff, as well as clinical research in the space specifically around fungal nail infections, which in my opinion has kind of been quite imperative to our clinical success that we've had under our brand, Fungal Nail Solutions, and the information that I like sharing with you all in these kind of presentations. I guess one of the questions that Anne proposed to me before I came on was how I was kind of, I guess, inspired to focus on fungal nail infections. It's not necessarily one of the sexiest things that is in the podiatry world, particularly coming out as a new grad podiatrist. But I think, in all honesty, fungal nail infections kind of found me. I didn't think I'd be leaving school thinking that this would kind of be me for the next 40 years, but look where I am. And I guess in saying that, by following this pathway, what it's allowed me to do is really become sort of an expert in an area, which is totally satisfying for me. But ultimately what it does is it also allows me to install a lot of confidence into my patients due to the kind of extended knowledge that I have compared to other practitioners that they've visited, whether it be another podiatrist or whether it be a GP or other medical professional. And it's also something that I continue to try and install within our staff group as well, is what do you want to be known for in your clinical space? How do you want to be different? How do you kind of want to be apart from the rest of us, I guess? And it's creating that clinical point of difference, that go-to aspect that you have. And I think patients kind of come into our clinics incredibly despondent and feel quite hopeless when they arrive at our clinics. But I think ultimately we're able to give people hope, happiness, and for the most part, a successful outcome, which in turn, I think, creates a massive overall boost in a patient's quality of life, albeit cosmetically, which is kind of what we all strive for as health providers. So I guess in essence, how I've ended up here is I've seen a gap in the market and I've kind of just jumped on it with both arms. So in essence, I'm a physio that treats fungal nail infections, which is quite an interesting mix. Obviously, I'm a podiatrist as well. But before sort of Tracy jumps on and introduces herself, just from my perspective going forward with the format here, obviously answer the questions that are coming our way, but I'll try not to repeat myself too much based on a lot of the content that's been discussed quite a lot in depth within the previous webinars. I'll definitely touch to it and kind of briefly discuss a few sort of more pertinent points. But if there is anything specifically that I kind of briefly glance over that you want to know in a little bit more depth, either please sing out, or alternatively, I'm sure details will be at the end of the webinar. I'm more than happy to have a more one-on-one conversation with people if they want a bit more clarification on certain things. Over to you, Tracy.
Cool, thanks, Cam. So my name's Tracy. I'm obviously the clinical nurse as well as the practice manager for Foot Foundation. So the reason I entered into this aspect of business is pretty much through coercion from Cameron, to be fair. So he and I coached and managed hockey teams together, so we knew we could work together and we had skills that complemented each other. So entering into the foot world has pretty much opened up my eyes quite significantly to the endless possibilities and realised how important people's feet are for their overall health and self-esteem, but also that people are prepared to go to pretty big lengths and pretty prepared to spend quite a lot of money so they can wear Birkenstocks and bare feet, pretty much. So my role in the clinic is staff wellbeing and HR kind of stuff, because of course our staff are our biggest assets. But I also have pretty reasonable administrative role, and I also do some of the clinical stuff as well.
Thank you, Tracy. So Cameron, obviously spoken like a true clinician, you have your patient's heart, sort of front and foremost when you're making these recommendations and doing these treatments. Could you sort of introduce to us this evening some of the things that you do, and share with us some of your most effective outcomes?
Yeah, absolutely. So, I mean, I guess people are here tonight, I guess, to try and understand modalities that maybe they don't have within their clinic. So, I mean, access to oral medication, topical solutions, all that kind of stock standard stuff. Probably not going to spend a lot of time talking about, but I guess looking at technology in particular around treating fungal nail infections, we do use 3 different types of technology within our clinic. So we actually use ClearNail, we use a form of photodynamic therapy, as well as obviously the Lunula cold laser. So I can kind of speak quite specifically to those 3 modalities in particular, because I obviously deal with them on a daily to weekly to monthly basis. Outside of that, I probably don't have a lot of knowledge. Obviously read studies, but I don't think it's fair to necessarily talk about things that kind of fall outside my experience and my clinical knowledge. But I'll kind of talk to those 3 because obviously I'm pretty profound in using these 3. So I'll kind of start with ClearNail, which is an interesting one. So obviously for those of you who have it, or those of you who don't have it, and those who have no idea what I'm talking about, basically what it is, it's quite a precise treatment by basically drilling small kind of micro holes into the nail plate, which in essence kind of allows for effective drug delivery to reach the nail infection, which, as we're probably well aware, the fungal infection sits on the nail bed itself. So we need to try and get best access to the nail bed. It sounds quite gruesome, obviously drilling holes through a nail plate, but it does have an automatic stopping mechanism that does prevent damage to healthy tissue. And so it does enhance patient safety to some extent. It is non-invasive and doesn't require obviously oral medication and surgery. And so from that perspective, it's a massive tick for patients. And I guess where we probably have its place, all of our treatments have a place within our clinics. The one place that it probably does have its place is for people that live out of town. So for some patients, one ClearNail treatment is all they need. Other people need multiple treatments, but probably for those more mild to moderate ones, one treatment session of ClearNail is usually sufficient. So where we tend to find this quite important is people that travel out of town who can't necessarily come to our clinics on a regular basis. And given the fact that we do run a relatively expertise clinic, we do have a lot of people that sort of travel all the way from the South Island all the way up to us, but also all around the North Island to come and seek our expert opinion. So there are some cases where one-off treatment is available for ClearNail. So that's probably where it kind of sits in our sort of space. But I guess looking at more how it doesn't necessarily fit in our clinic is in the same breath. Some patients, particularly with the more moderate to severe infections, do require multiple treatment sessions. So again, that doesn't really help people that are living out of town. However, the time between treatment sessions is relatively large. It is a little bit dependent, this modality, on practitioner skill. So the success of this treatment does kind of balance on the practitioner's ability to, number one, drill the right number of holes, but also get the spacing of the holes right. But I think what's also really important is the drill pieces themselves are incredibly fine and snap incredibly easily. So for practitioners who are not very experienced in using it, you can probably snap 2 or 3 drill pieces, not uncomfortable for the patient, but what it does is it basically bleeds your bottom line, because it works like a toner and a printer situation, whereby the machine itself doesn't cost an awful lot, but the drill pieces you have to buy, and obviously they're only single use. So every piece that you snap, it's a new piece that goes on for the same treatment, and obviously the profits go down. What else around that? It can be a prolonged procedure. So like if you've got a relatively large adult male big toe, you're probably looking at somewhere between 10 to 15 minutes of micro drilling to get a moderate to severe infection completely drilled. And so from that perspective, it can be incredibly time consuming if you do have multiple nails that you have to be doing. So again, one-off treatment, out of town, one toe, fantastic. But as soon as we start getting 3, 4 toes, it does become incredibly time consuming, and then you have to kind of weigh out the cost benefit ratio, particularly when you start putting your business hat on and start taking your clinical hat off. Pain is unlikely, which is really awesome, but the drill piece can get warm and it can become a little bit uncomfortable for patients, which can cause their foot to sort of move or twitch. And you guess it, as soon as they move their foot, drill piece snaps, new piece goes on, and then again, it starts bleeding your bottom line again. We use and advertise this modality on our website, but what we tend to find is not many people kind of are attracted to our clinics because of it. And I think it's really quite simplistic in the sense that no one wants little holes or drill pieces drilled through your nail plate. I'm not bagging it as a treatment modality, because we absolutely use it in our clinic, but it's not necessarily a magnet or a draw card to bring people through the door. It's something that we then have to kind of educate later down the track if it is suitable. And I guess the last aspect of it is topical compliance. So a lot of patients arrive to our clinic because they are either sick of using topical or they haven't been very good at using it. And ultimately with Clear-A-Nail, all Clear-A-Nail's doing is becoming a facilitator to treatment. So in essence, it's enabling the topical agent to get to the nail bed where the infection is. So if compliance is an issue or the patient doesn't want to be using topical agents on a regular basis, again, Clear-A-Nail is probably not the right kind of treatment for them. So the next one that we use in our clinic is photodynamic therapy, which again, real positives is that it's non-invasive and pain-free, which is a massive tick, obviously, for the patient themselves. It obviously specifically targets fungal cells, which obviously minimizes damage or destruction to healthy tissue. And from memory, it uses a 630 nanometer wavelength, but it actually works in a very similar way to how the Lunula works, in the sense that it creates a hydrogen peroxide reaction by using the light and the methyl blue to actually kill fungal cells. And where it probably fits in our practice is there is some evidence, and there's not a lot of evidence on how these technologies as a whole work on non-dermatophytic infections and yeast infections. So there is actually a small body of literature that actually looks at photodynamic therapy and its space in non-dermatophytic infections. And so for us, we probably only see about 5% of our total caseload, bearing in mind we see maybe 12 patients a day, every day, through most of our clinics. So we see a lot of patients. Not many of them present with a non-dermatophytic infection, but this is probably where we find this particular treatment modality to be quite successful in those non-dermatophytic infections. We are currently going through an in-house clinical trial at the moment with yeast infections to see what kind of response rate we do get with it at the moment, but it's very early days in that space, so I can't give out too much around that, but it is something we are currently sort of working towards. And I guess the other nice thing about photodynamic therapy is that there's kind of no adverse event reactions or sort of adverse events that's kind of been reported in studies. But I guess looking at the two cons, or the two big cons really, is number one, treatment time, and number two, the kind of blue staining that goes on with it. So treatment time itself, particularly if we look at packed therapy, you're looking at kind of 10 minutes for the gel application. So you're applying the methyl blue to the affected nails and potentially non-affected nails. But then that's also followed by a 9.5-minute cycle on each toe involved. So 10 minutes can be used across all of the toes that are required. So if you have 3 toes, it's still 10 minutes. But if you do have 3 toes, that's 3 9.5-minute cycles thereafter to treat each toe. And you're looking at, I mean, everyone has different treatment protocols, but I guess a lot of the sort of pack therapy is 3 sessions in a week and then kind of repeating that over a period of time. So there is a large, again, time-consuming element to this treatment if you have multiple nails. So again, works quite well for a singular nail, works well in a nice 30-minute appointment. But as soon as we start getting 2 or 3 toes, if not more, in a lot of cases in our clinic, we see a lot of 8 to 10 toes, that becomes a massive issue, again, putting the business hat on in regards to, are we getting cost analysis benefit versus the clinical hat? Is it the right thing to do for the patient? And in non-dermatophytes, maybe, but again, becomes a bit more challenging with multiple toes. And then the last thing around the photodynamic therapy is because we're using a methyl blue type substance, it does cause the nails to stain blue. And so what we tend to find is the blue staining tends to occur quite prominently on the infected aspects of the nails And in essence, it's a nice indicator actually, because it tells us what aspects are still infected and what are not, because it doesn't tend to last on the healthy nail, I guess, for long periods of time, but definitely in through the infected cracks and crevices, the blue staining will hang around for a relatively long period of time. And so what that in essence means is you've got an aesthetic problem. Now, for the most part, fungal nail infections are a cosmetic fix. People are coming in to see us because they don't like the look of their nails. So if you're then going to go and put a whole lot of blue staining on their nails, then all of a sudden they're going to hate you even more. And so what we tend to find is that patients, particularly as we go into summer, in New Zealand anyway, patients are less inclined to want to go down this treatment pathway, because then they're putting their jandals on, and yes, they've got a fungal infection, but now they've also got blue toes as well. So it becomes very much more so of a seasonal treatment modality for us. We have more people uptake it during winter when they can hide their shoes, their feet, sorry, but obviously during summer, it's not necessarily a massive turn on for people. And obviously, again, looking at treating fingers, because we treat a lot of fingers, it's almost game over from the blue staining perspective. I don't really want to talk a lot about hot laser because I don't use it personally. I don't have any experience with it. But if anyone else wants to pipe up in that space, I'm more than welcome to. But I don't feel as though I necessarily have massive credentials to talk in that space. But obviously, is another quite prevalent device that is out there, or technology that is out there. But I guess the last one that we look at, and is a real jewel in our crown as well, is the Lunula cold laser. And we use all three modalities in our practice, but by far the Lunula cold laser is the one that we do use the most of. And I can say that because we do use all of the modalities and the numbers don't lie. Obviously, as people are well aware, there are a reasonable amount of studies out there to suggest the efficacy of growth rates, which is really awesome. It's obviously automated, so it's not user dependent, unlike the clear nail. So you can have obviously yourself operate the machine. You could have a receptionist operate the machine, or the patient could even operate the machine themselves. And we'll talk about that a little bit later, I think. But it's also painless, and obviously it's hands-off both for the practitioner and the patient. So you can obviously have a nice discussion with the patient, or the patient can do their own thing without any requirement for any manual sort of therapy like the clear nail, and obviously like hot laser and other bits and pieces.
Okay.
No. Yep.
Just before we sort of move on to the next topic, there are a couple of questions that have come in. What topical application do you use with clear nail? As the question comes from someone who believes that it needs to be water-based to avoid clogging the holes.
Yeah, so most of the research that I've looked at is more terbutafen-based products, and that's probably more so what we go for. So again, the way I kind of look at it from a delivery point of view is, you know, I kind of go back to the oral medication space and go, oral terbutafen tends to be first-line drugs for dermatophytic infections. So what we tend to do is, but we tend to go with a spray. Most of the studies will actually look at spray-based products rather than lacquers and things like that, things that kind of cake on. So we tend to go for a more spray-based product. And when we're particularly dealing with dermatophytic infections, we'll tend to go for more terbutafen-based products.
Okay. Just another question that's been asked a couple of times now, and it was discussed in the earlier webinars, and that is that you do a test for everybody before you actually start on them on any treatment pathway. Is that still the case?
Yep. So generally speaking, most of our patients will come in and we will dye factory them, which is a nice, easy 5-minute test. And I'm sure most people are quite familiar with the dye factory test kits, which are testing for dermatophytic infections. Obviously make up about 90% of infections, so it's a pretty good hit rate. Obviously, yeast and non-dermatophytes don't get picked up in these, and they only really are specific to culture. So if we suspect yeast infections or non-dermatophytic infections or molds, then we have a pretty good relationship with the labs, and we work quite closely with them around picking up specific organisms and things like that. And so a lot of our patients will go to the lab to get tested to ensure we get them on the right pathway. It's a patient choice. Obviously, patients will spend, $100+ going to get this done. So we give them the option as to whether they want it to be formally diagnosed before we start treatment, or whether they're happy for us to proceed with treatment either way. And that ultimately comes down to what the patient feels comfortable with. But in a perfect world, everyone would have a diagnosis before we start treatment.
Okay, thank you very much for that. So, Cameron, your treatment techniques to improve the customer outcome is all on sort of your decision as to which road you're going to go down, which treatment process you're going to go down. That's just been made, pretty clear that you decide what's going to be the best for the best clinical outcome for the patient. Mm-hmm. Can I just ask, from a point of view of, we obviously think that the jewel in the crown is the Lunula laser. The fact that it's an unattended procedure, it's painless for the patient. Do you think that they do sort of compare those things when you're offering treatment packages to them? Do they look and say, well, is this going to hurt?
Yeah. So I think the biggest thing for us to draw from a lot of that is all of our treatment modalities get advertised on our website. So obviously people can go onto our website and sift through the different treatment modalities that are available. And hands down, I would say probably 9 out of 10 of the patients will be inquiring about cold laser. Not a lot of them will be inquiring about the other forms of treatments. And I guess it's relatively new. It's unknown to people, and so people see it as being a really good way to kind of move forward. Most people are drawn to the fact that it's obviously pain-free, which is fantastic. But I would say absolutely it's a jewel in the crown, not only for you guys, but for us as a clinic, because what it does is it creates a magnet to draw people into our clinic. We find that a lot of our patients basically want to start treatment on the same day. They don't really want to go through an initial consultation as such. They just want to rip straight into cold laser. And I guess what you've kind of gauged from me so far is that actually, like, I really emphasize taking a step back, making sure we get the diagnosis right and the treatment plan right before we start down that track. But by all means, most people are drawn to our clinic because of the fact that we have the cold laser over the other modalities that we still advertise on our sites.
Okay, so on that then, your treatment techniques to improve the patient outcome, do you still advocate that total nail avulsion is the best way forward?
I think it's case by case dependent. I think removing nail plates in the treatment of fungal nail infections can be incredibly successful, particularly when we start dealing with sort of total dystrophic infections. I think, there are certainly risks associated with removing a nail plate. Obviously, in the early stages, we have obviously risk of infection, delayed healing, pain, because we're obviously opening up nerve endings. But once we start getting down the other end of the spectrum, when the nail plate starts growing back distally, we obviously can run into problems with sort of ingrown toenails getting stuck in those sort of distal sulci, but also because the plate's been removed, we can end up with kind of disappearing nail beds and actually nail plates that don't grow back quite as large. So it's definitely something that we use quite often for our total dystrophic infections, but I wouldn't necessarily say everyone that comes through the door is getting their nails whipped off, because I don't necessarily think it's the best treatment course for everyone. Plus, obviously, any treatment technology, particularly cold laser, like it's not cheap for the patient, and so we always have to be discretionable as well in the fact that as soon as we start going through an avulsion, it adds another expense onto the patient's bill. So if we think it's appropriate and clinically right for the patient, absolutely, we'll look at that. But if it's not necessarily clinically appropriate, then we won't tend to go down that track. And we have pretty strong clinical guidelines around what constitute what kind of treatment. And so we stick to those pretty well, with obviously some discretion and wriggle room depending on the patient themselves.
Okay, thank you for that. So I guess once you've sort of you've got the results of the tests that you've done, and you've discussed the treatment options with your patient, what's your next step? Do you sort of ask them, do you discuss payment at that point? Who brings the subject of payment up?
Yeah, so I think the biggest thing that we do is in that initial consultation, it's really important for us that the patient is autonomous. The patient is in the driver's seat. So our job as clinicians, in my view, is to facilitate the conversation and the patient is in essence in the driver's seat for the most part of that initial consult. Once the patient decides to go down a treatment pathway, then in essence I become the driver. But what we don't want patients to do, particularly as we start getting into these kind of big ticket treatments, is kind of feel coerced into going down a particular treatment pathway. So the way we kind of structure our initial consults in regards to payments is all patients are given sort of 2 to 3 different sort of treatment options that are available to them. And so generally speaking, we'll basically play out all our cards, and we're in quite a fortunate position where we have multiple different modalities to be able to offer people. But in essence, what we tend to do is we tend to give them 2 to 3 options that are suitable for them. I think that's quite important. And then we kind of talk about sort of the success they might potentially have with each of those modalities. We'll obviously talk about what's required from them for each of those modalities in regards to what they have to do outside of the sessions, how many times they have to come back, et cetera, and what that full process looks like. And then as well, we obviously look at what the costs of each of these are as well. So I think from our perspective, patients come in and they have choice. And I think that's really important with any sort of treatment that we offer patients, whether it be in the fungal nail space or anything, is patients want to feel as though they have a choice. And 9 times out of 10, whatever options we give them, patients will choose the cold laser. And I guess the patients that don't choose the cold laser, generally speaking, is either cost, or at that particular point in time, they can't necessarily commit to, coming in every 2 weeks or 1 week or whatever the protocol is for them. But it's important that we give them choice. So if a patient goes, oh, no, I can't afford it, not at this time, like petrol prices have gone up, I'll tell you what, they're just going up like a ridiculous at the moment. It's hurting me in the back pocket. But in essence, what the patient may choose at that point, because they've got options, is going, cool, I'm going to go with the topical at the moment because that's all I can afford. And that's cool. But what you do is you keep them in the system. And I think that's a really important aspect. And so then as you're seeing them every sort of 8 to 10 weeks doing debridement to kind of facilitate that topical agent, they know they don't have a very good chance of it working because you've explained that to them at the start. But that's the choice they made. And then what might happen is 6 months later, your patient gets a promotion or whatever that looks like. Wife goes back to work after being on maternity leave or what have you, and all of a sudden they got a bit more money. And so now they can afford it. But if all you give them is cold laser, can't afford it, see you later, then you've lost them. And I think that's really important. So giving them choice. And so if you've only got a cold laser, or if you're considering purchasing a cold laser and that's the only kind of, I guess, technology that you've got in your clinic, still offer them topicals, still offer them orals, because what it does is it allows people to stay in the system. And I can guarantee you that 9 times out of 10, if cost being the biggest issue, if cost isn't the issue, they'll jump on the cold laser all the time, because that's what we tend to find through our clinics. But not everyone can afford it, but it is so important to keep them in the loop so that later down the track, it may be an option for them. And that's how I probably discuss price in a roundabout sort of way.
I think that's an excellent answer, and that is, it's ultimately it's the patient, and we all know that there's times when people can afford things, and there's times when they just really can't. So, I guess that gives me a sort of pointer to our next subject. We have got a couple of questions. And somebody's asked, how much is a session for the Lunula laser? Now, this is the question that comes up with every podiatrist that inquires about purchasing a Lunula. And I'll be 100% upfront, and I turn it back on to the podiatrist. And I say, well, it really depends on your demographic in your area, because you cannot expect every clinic to charge the same if they've got maybe a presence in a wealthy area or in a lower demographic, socio-demographic area. So I think it's a hard one for a podiatrist to say, oh, look, I really don't like charging them too much, etc. But if you get the patient to commit to taking a course of Lunula treatments, i.e. 4, 5, 6 treatments, then you're probably better off packaging the pricing at the very beginning. and asking them to commit to that so that they do keep coming to the practice to have the treatments? Or maybe, Cameron, do you charge them each time they come and hope that they continue with the 4, 5, and 6 treatments? How do you broach it?
Yeah, I might let Tracy answer this one.
Okay, great, perfect.
She's the money lady. So
welcome, Tracy.
So I think in New Zealand it's slightly different to Australia. We don't have Medicare here, and our standard rate for health insurance is very low. So people are paying out of their back pocket 90% of the time here. And our psych is very much not to pay things up front. So people like to pay as they go. So we prescribe, so as Cameron said, we have an initial consultation that they pay for, and whether they choose to go with treatment or not, that the initial consultation is the initial consultation. And at that consultation, they will be given exactly what the course of treatment is, how much it's going to cost, the length of time, and that it's a pretty much a 12-month commitment to be able to see that the best results for that. And so we're very, very upfront about expectations and money. But what we do know is that people come to us because they have exhausted all their other options. And so in that consultation, as clinicians, it's important that you bring them along for the ride, as Cameron has said. And so when we get that, they know exactly how much every single session is going to cost. Yes. Now, for us, our cost base is on debridement and appointment time. So if it's a single foot, which requires minimal debridement, it's a half-hour appointment. And if it's a more comprehensive one, 10 toes or something like that, we would have a 45-minute consultation, and the price reflects it. There's no doubt that in the wealthier areas, so we have 4 clinics based around the Upper North Island, and in our wealthier suburbs, people don't even blink. In fact, a lot of people go, oh, is that all it is? And then in our other areas, which are probably a little lower decile ones, people are prepared to pay for it. And I think the reality is there is no other option. And for us is not about, we're about building relationships with our patients to ensure that they realise that we're there to get the best outcome for them and to try and find a solution. So they're coming to us with a problem, we've got the solution, and with that, they're prepared to pay for that.
Yes, yeah. And, it probably one of the things that you get asked when you're sort of managing the bookings and doing the reception is, can I pay for it, each time I come, or do I have to package it? So we've covered that. And I guess that's part of the decision that as a podiatrist, you have to make when you're going to put it into your practice. You have to look at how much you're going to make on your return on investment. Because let's be honest here, everybody's in it to make some money for the practice, because we don't live on fresh air. So let's be totally honest, the cost of the machine, you've got to work out that you're going to get a return on investment. So I think, Sherelle, if you could just bring up the slide that we have, and you will see that the cost of the Lunula laser, and it all works out at how much return you can make per month and cover the finance commitment, as to how much you charge per treatment and how many patients a week you're going to be putting through. So Sherelle will just give you a demonstration now that if you had 5 patients per day, how much revenue you could be making per month. And over the year, you're more than covering your outgoings of your finance. So that's just a simple ROI figure that we typically work on when we're suggesting how you're going to make your money, so that you're not actually left out of pocket when you're treating your patients. I think in the previous webinars that we've had, we've discussed how many treatments each patient is likely to need. The minimum is absolute minimum is 4, 5, and then you bring them back and you give them a 6th treatment. And the months apart is dependent on the severity of the case in the first place. So we've covered all that in previous sort of webinars, and it is covered in the data and everything that ReaCare do supply to you. But that's just an insight as to when you make your investment in the Lunula, as to what your expected monthly payment would be for the finance and what your return could be. And I'm basing this on a single podiatrist using the Lunula in a clinic. If you've got 2 or 3 podiatrists in the clinic, you may get that you're getting 6, 7 appointments, 8 appointments, and the reception staff are left to do the 2nd, 3rd, and 4th treatment, because you've done the first treatment with the consultation and debridement, and then the reception staff are doing the 6th, 7th treatment. So you don't have to always be there. You can carry on with your other work because you've got lots of other things that you're doing on a daily basis with your patient group. So yes, we do discuss money. We do discuss it because it's something that everybody asks. Tracy, can I just sort of bring you back to your role in Cameron's clinic? Do you get involved with each patient that comes in, and how do you sort of go about your day?
No, so well, I spend a lot of time doing administrative stuff, obviously. So for us, we have an administrative team, and that initial phone call is a first impression. And so usually the first call goes something along the lines of, I want to come and have cold laser. And
Sure.
so our job is to obviously persuade them that whilst that probably is the right course of treatment for you, it's important to come in for an initial consultation, and
Yes.
we explain why. It's because we talk about, it's a huge investment of time and money from them. And so for us, it's making sure that we get the right diagnostics so that we can get the right course of treatment. So we tailor it to them. And so I think it's really important that the administrative staff are on board with the clinical understanding. Obviously, we're not clinicians, and we don't have the same depths of knowledge as the podiatrists. But if you just go, oh no, you have to come in for an initial consultation, and the patient doesn't understand why they just can't come in for laser, they'll hang up and go somewhere else. So that's a hugely important part of it. I actually do have a clinical role in it. So we get a lot of hands, people who have hand problems, fungal nails in their hands or other things. And so I do a lot of clinical work around hands, because obviously not all podiatrists feel comfortable doing that.
No, we do know that there are a few podiatrists that have some great success with treating fungal nails in the farming regions of Victoria and New South Wales, where they've got patients that come to them with fungal nail, foot fungal, also hand fungal, and they do treat both. I think it's fair to point out that because the how you use the Lunula laser, the patient would have to have it mounted on a table and put their hands in. And if you're obviously treating feet, then it's on the floor and it's an unattended procedure. They just put their foot in and then swap feet. So 12 minutes per foot. I see a question come in, how long is each laser treatment? And that's the answer, 12 minutes per foot. Now, every podiatrist would probably suggest that if you've got fungal infection on one foot, you should always treat both. Am I right there? Would you do that, Cameron?
Technically, yes. Reality, no. I think it's a really fine line between, I guess, clinical and obviously business hat. In a perfect world, you would. If there's absolutely no sign of infection, then I would say using kind of topical sprays, or just really making sure that hygiene and sort of routine was being done across both of them, then I think that's enough to kind of try and stop reinfection. But the reality is you're another 12 minutes for a preventative measure. And it increases the price for the patient as well. So if you were to ask the patient whether they want the other one done, which is going to cost you more, but it's going to be for preventative, I would say probably 80% of them would say, no, don't worry about it. So perfect world, yes. Clinical hat on. Business hat on, probably not.
Interesting. I know on an earlier webinar when we had them with the US, there was a particular doctor there that said, if somebody presents with fungal nail, it's a wife or a husband, I would always say, bring the other one along because you've both got to get treated because you passed it over the bed sheets. So that's interesting that you don't always make them go down that route.
Yeah, I think the other big thing around the American system is the insurances. Like those dermatologists are blooming taking the clip in the ticket every time of the way. But I think you bring up quite a good point there, which I just want to kind of just tease out a little bit. We get a lot of patients, and I'm sure plenty of people can kind of relate to it a lot as well, is you read online and look at research and go, it's incredibly infectious, and every place you go, you have the risk of getting infected. And we have patients that have had infections for 10, 15, 20 years, and their spouse has never got it. Now, they share the same shower, they share the same bed, they share the same house, and not once, shame to see a laundry, they have never got it. And so I believe personally doing a bit of reading around genetics and things is actually people are genetically their disposition to getting infections is a lot higher, but it's more a genetic component. So I personally think there's more of a family connection there. And when you then tease that out a little bit and go, do you have a family history? And we'll go, oh, your dad had it, or sister has it, or mum has it, or whatever, far more than does your spouse have it. Absolutely. If the spouse has it, you want to make sure you treat both. But if the spouse hasn't had it for 20 years, then unlikely that they're going to get it in the next 10. So I always ask the two different questions. Do you have a household contact that has an infection? But also, do you have a family history that have an infection? And I think they're two quite different conversations to have with patients. Sorry, that was just a little
yeah, no, that's fantastic. And look, this is what this sort of third webinar is all about. It's just about discussing the things that everybody thinks of, but nobody thinks, oh, I should ask it. So well done for bringing that one up again. Just sort of going through some of the questions that have been asked. What would be the rough price difference between clear nail packed and cold laser? Oh gosh, I can only tell you about the cold laser price, which we've just put up. Clear nail and packed, I don't have a clue. I wouldn't, I've never worked in that side. So I'm sorry, I can't answer that question. We've covered how long does a cold laser treatment last and how successful is this treatment. Probably Cameron, I know that we've discussed it in previous webinars, but could you just go quick summary of some of your successes?
Yeah, so I mean, you can look at the research, and each research paper you look at, you get varying differences. And I always, I guess, talking more clinically here rather than more sort of with the research hat on, is, yep, you may read an article that goes 89% clearance rate, but not every individual going through that is going to be exactly the same. And what I tend to say is and I've talked about it a lot in previous webinars, is a lot of people have different negative prognostic factors associated with how they present. And they may be more local factors, they may be more environmental factors, they may be more personal factors, but there are a lot of prognostic factors that influence the patient's chances of success far more than looking at one paper and looking at the percentages. And there's obviously great research out there, and I'm sure RearCare has all the research if people want to look at the research-based stuff in more depth. But I think looking at it from a clinical perspective, I personally think that success comes down to how well we actually manage the person and how well that treatment protocol is put together, more so than just the device itself. And so if we had a patient, if we told two patients, and I don't like using percentages when it comes to discussing it with patients, I always tend to more go down the route of what's potentially going to be more successful than another, because I think you almost stitch yourself up by putting numbers into it. I think you can use research to sort of suggest numbers, but reality is not everyone in that research protocol is going to be the same as every patient that comes through the door. So I tend to, from looking at success rates, I tend to suggest what's going to be more successful than another. And I think if you were to say to a patient, hey, look, 2 patients present with the same infection, you're going to have an 89% success rate. And you have one patient that literally just comes in, puts their foot in and goes away and doesn't do anything else. And then you have another patient that addresses all of those negative prognostic factors. The likelihood of success is going to be far higher for that person compared to the other person, despite having the same infection. So I think I really try and avoid putting numbers on it when it comes to discussing with patients. If patients ask, then absolutely I'll go down that track. But I more try to, I guess, rank what's going to be more successful over another modality rather than telling them that they have an X percentage chance of success. And I know that's probably a cop-out answer, but I truly believe that your chances of success, or your patient's chances of success, come down to removing negative prognostic factors and really making sure that that full treatment plan is implemented, short of them just coming in and putting their foot under the laser.
Sure.
Kim, would you say that from our clinic's points of view, is that like 85 to 90% of the patients that come through our clinic end up having cold laser therapy, and the other 10 to 15% is scattered amongst all of the other modalities?
Yeah, I'd say that probably off the top of my head would be about right. Yeah.
Mm-hmm. That's really, sort of an excellent analogy of it all, isn't it? Is that your patients prefer cold laser. That's
and I think coming down to that point as well is what I alluded to previously. All patients have choice. Not all patients are coming in being coerced into doing it. And so that 80% to 85% is coming from patients choosing that that's what they would like to do, rather than me telling them that this is what they have to do. And I think that's another important piece of the jigsaw puzzle to look at when we look at those statistics.
Yeah, okay. So can I ask then, when you've got your patient in front of you and you've presented what their condition is and you discuss the treatment, how long do you typically keep that patient on your books? Are they yours forever?
Oh, I wish. Some of them are, and I wish they weren't. No, just kidding. So usually, if treatment's going to be successful from day one, and people do have to make up the negative statistics, unfortunately, and that goes with all treatments. But with a successful treatment protocol that's implemented from day one, usually that full loop is 12 months. Yep. And so normally I will not discharge someone until they've at least done 12 months with me. And the reason I do that is we have a lot of patients, particularly when it comes to oral medication, that have been on oral medication and it's come back. And there's quite a difference between a clinical cure and a mycological cure, yeah? So clinical cure, you look at it visually, looks really good, fantastic, discharge, see you later. They'll be back in your door 6 months later with a new fungal infection because you haven't got a mycological cure. Ultimately, you need that time. And it depends a little bit on the severity of the infection. Like if you've only got like a distal third infection, you probably only got them on your books for 4 to 6 months. But really, we need to make sure that that distal aspect of the nail plate is completely clear with no striations through it before they're discharged from your service. And so I guess for your more gnarly ones, your kind of full nail plate ones, you're probably looking at minimum 12 months. But most patients are very well aware that they will not be getting discharged until we have received or got a mycological cure as well as a clinical cure.
Okay, thank you very much. Do I have any more questions? Would anybody like to ask a question of either Tracy and how she manages the day-to-day running of the podiatry business, or a clinical question to Cameron? Or does anybody want to ask me a question? We do have one. Oh, how do you test for the cure?
So generally speaking, it's how they were tested in the first place. And that's the important aspect of testing at the start. And so if you've got a dermatophytic infection at the start, then you should be able to retest with a diphactory or whatever test kit you use and get that negative test result. Again, that comes at a cost to the patient. So again, it becomes the patient's choice, but you're educating them around what choice they want to make. And ultimately, the patient goes back into the driver's seat. We have 2 choices here. Either you can go away now and you can just monitor it. And if you start seeing signs of infection, then we can then you can come back. Or alternatively, we can send you to a lab or we can retest and determine if mycologically you are cured. And so if that is the case, then we have a lot more certainty that we're kind of out the other side, and you've got a much better long-term prognosis with someone like that compared to the wait and see type approach patient. And there's probably, in all reality, a 50-50 split. Some patients couldn't care. They'll just go away, and if they notice anything, they'll come back. And then other patients will much rather, they've been through a lot, they've invested a lot of time and money, and want to make sure for certain that they have got that result. But that becomes important that we get the first initial test right as well. And if you don't have that initial test, then you have nothing to compare against.
Okay. Just one of the things that's come to mind, we used to use a product, and we still we've reintroduced it now, but that is to actually sanitize the shoes that the patient comes to the consult in. So it's called Shoes App. It used to be called SteriShoe, but we had to switch products because of the manufacturing. But do you use such a thing in your clinic? And do your patients go on to buy them and then treat the whole of the family's shoes as well?
Yeah, we do. Yeah, we do. So as part of the whole treatment course, it's not just about treating the toe or the foot, it's about treating the whole person. So every time they come in for a laser, they bring a pair of shoes with them, and we will sanitize them through the SteriShoe or the Shoe Zapper.
Sure.
And some patients will buy them. Our farmers particularly buy them for their gumboots because they're too embarrassed to bring them in.
Yes.
And we have so we definitely do. And I think that's a really important aspect, is that you always have to treat the whole person, not just the toe or the foot.
Sure. We have got another question come in. They apologise for not seeing any of the previous webinars. But what advertising do you do for your clinic? I know that from a point of view of one of ReaCare's sort of backup services, support services, is that we provide the digital advertising for you to load onto your own website, so that you can advertise that you have cold laser, and it pre-informs the patient all about it. But you can also put your own advertising on. And how often do you advertise as a clinic so that you get a churn of new customers?
Really cop-out answer. We have someone else do it for us. So we don't really, I guess, I think, we're good at what we do. One thing I'm not very good at is marketing and Google ads and Facebook ads and all that kind of stuff. So we just have someone else do it for us. We meet with them every so often. I think the one thing that we do have a little bit of input in is kind of when we advertise. And I guess there's two arguments to it. Number one is, we tend to numbers pick up a lot through summer, because obviously people are getting their toes out and are starting to become embarrassed. But actually, coming back to that kind of 9 to 12 month process in regards to how long it's going to treat, really you want to be capturing people in March, April, so that by the time they get through to summer, that they're actually in a much better position. And it's much harder to portray that message, to go, hey, if you come in now, we can have them ready by next summer, because people want them ready now. And so we probably still get more people coming in during summer. But in essence, what that does is it ties you over through that, I guess, quieter period through winter, because patients are on your book for that sort of 12-month window for the most part. So we use various sort of platforms in regards to advertising, but we don't do that ourselves. So I'm probably not the best person to ask in regards to expert questions around marketing. It's not what I'm good at, so we pay other people to do it. As the short answer.
Mostly digital.
Yes, absolutely. And ReaCare do provide all the digital advertising for all the information on the Lunula, and of course we do provide the training for the staff. We ask you to register all your podiatrists, the team of podiatrists, and also the reception staff into the Econia library, which means that they can go on and do an online training course, so that they're fully aware of what the Lunula does, because it's important that everybody in the clinic knows about what instruments and what's been used, and they can explain it to patients. And we do have patient brochures as well. So that's that question I think we've answered that. Does it go through social media? You can do it through social media, but as Cameron explained, we did have one question. Sorry,
I can pipe in again. Hi, everyone. My name is Sherelle. I'm the marketing manager of Reha Care. What we do provide as part of our service as well is a marketing strategy guide that basically helps new business owner basically optimize their website, because that's where you mainly capture new patients coming through your doors. And we also have some strategies as well and templates for social media advertising. So those are something that we do support as well.
Perfect. Thank you very much, Sherelle. Thank you. Is Lance Penn still on? He did have a question. I don't know if he's still on. Give him the opportunity to ask it. Lance, are you there, or have you dropped off again?
He's dropped off again.
Okay, all right. Can I just say a big thank you to Cameron and to Tracy for the series of webinars that we've been holding with this subject. We will have questions come in, I'm sure, from people who go to bed tonight and think, oh, I forgot to ask it, I didn't ask it, but you can contact us, and we will be sending out an email as a thank you for attending, and Sherelle will be doing the certificates, and we will have a link to the recording for your sort of colleagues who couldn't attend this evening for one reason or another. And I will have a special promotion for the Lunula laser as well. So a big thank you for giving up your time to join us this evening. Thank you to Cameron, thank you to Tracy, thank you, Sherelle, for putting all this together, and have a good night. Thank you for joining us. Goodbye.
Thanks.
Thank you very much, guys.
Thank you.